Hereby, I open this academic ceremony in which Cécile Obeid will defend the academic thesis Mediterranean Diet in Mediterranean Countries. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Pro-Rector, members of the Corona, promoters, family, friends, online guests, thank you for attending my defense ceremony. In the next 15 minutes, I will present a summary of my research entitled Mediterranean Diet in Mediterranean Countries, focusing on determinants of adherence to the Mediterranean diet, specifically examining Lebanon in the context of the economic crisis. Let food be thy medicine, and medicine be thy food. This quote by Hippocrates reminds us that nutrition is not only about calories and nutrients, it's a foundational pillar of health. The Mediterranean dietary pattern illustrated here embodies this philosophy. So, building on the philosophy from Hippocrates, the Mediterranean diet translates this into measurable health outcomes. Evidence consistently shows its protective role in cardiovascular health, glycemic control, in weight management, cognitive function, inflammation reduction, and even reducing cancer risk, making it one of the most extensively studied and clinically supported dietary patterns worldwide. So what is it exactly? The Mediterranean diet originates from the countries surrounding the Mediterranean Sea, spanning Southern Europe, North Africa, and parts of the Middle East. Although each country has its own culinary traditions, they share a common lifestyle and dietary characteristics. As highlighted in this map, Lebanon is one of these Mediterranean countries, forming part of this broader cultural and nutritional heritage. So the Mediterranean diet is predominantly a plant-based dietary pattern, very rich and centered on fruits, vegetables, whole grains, legumes, nuts, olive oil as the main source of fat. Fish and seafood are consumed regularly, dairy, poultry, eggs in moderation, red meat and sweets very occasionally. And beyond nutrition, it also values physical activity, social eating, and cultural food traditions. Although the Mediterranean diet is increasingly adopted in countries elsewhere, in non-Mediterranean countries, this map shows that adherence with the traditional Mediterranean regions is often only low to moderate, and there are limited evidence from Middle Eastern countries highlighting an important geographical research gap. So the Mediterranean diet is losing ground where it originated, while gaining popularity elsewhere. Major evidence gaps persist regarding the determinants of adherence to the Mediterranean diet and the reason of its decline in Middle Eastern Mediterranean country, particularly Lebanon. So understanding current adherence trends is essential to design effective strategy to protect and to promote the Mediterranean diet. For this study, we used the socio-ecological model as our theoretical framework. The SEM actually conceptualizes dietary patterns as the result of interacting levels of influence. So there are individual factors such as attitude, knowledge, perceived behavioral control, interpersonal factors like family, friends, and peers influence, and broader environmental and societal structures, including food availability, pricing, and policy. It emphasizes that diet is shaped and nested by reciprocal layers, and that sustainable change requires a multi-level strategy. During the period of the study, Lebanon was undergoing extreme, and still is, unfortunately, historic economic collapse. Food accessibility, affordability were severely disrupted, rising food insecurity and dietary shifts, and limited evidence on the crisis impact on Mediterranean diet adherence and the determinants. So the diet must be understood within this context of economic collapse. The objectives of this thesis are mainly summarized into two axes. First, to provide an overview of the level of adherence to the Mediterranean diet and the determinants of adherence to the Mediterranean diet among Mediterranean countries, and then to explore individual, interpersonal, and environmental factors shaping adherence to the Mediterranean countries, shaping adherence to the Mediterranean diet in Lebanon via a mixed approach, a qualitative and a quantitative study. So our first paper was entitled Adherence to the Mediterranean Diet Among Adults in Mediterranean Countries. It aimed to assess the level of adherence to the Mediterranean diet among healthy adults living in Mediterranean countries. And for this, we conducted a systematic review as per the PRISMA 2020 guidelines. We included 50 studies. They were dated between 2010 and 2021 on adults aged 18 and above, and with a minimum sample size of 1,000. We searched 3 databases, PubMed, Web of Science, and PsycInfo. As for the results, in general, the study quality showed weak to moderate studies. The level of adherence was also low to moderate among adults living in Mediterranean countries, and evidence was primarily emerging from European Mediterranean countries with very limited evidence from North African and Middle Eastern countries. So, as a conclusion, Mediterranean diet adherence has been moderate over the past decade, indicating substantial potential for improvements in countries of origin. Our second study was also a systematic review aiming to explore socio-ecological determinants of MD adherence in Mediterranean countries. So for this, we have conducted the systematic review also followed the PRISMA 2020 guidelines, including studies on adults aged 18 and above, and there were 37 cross-sectional studies included. As for the findings, so on the environmental level, we found a consistent positive correlation between COVID-19 confinement and the level of adherence. However, economic crisis showed inconsistent effects. The interpersonal socio-cognitive factors were largely underexplored, and there were very limited evidence. The most studied factors were the individual determinants, and here we found a positive correlation between higher socioeconomic status, regular breakfast consumption, being unemployed or a job seeker or retired individual with MD adherence. So, as a conclusion, this systematic review identified key socioeconomic and environmental factors influencing MD adherence, but further robust research is needed to clarify sociocognitive and ecological determinants. Our third study, the last two, were about Lebanon in particular. First, we conducted a qualitative study aiming to explore determinants of MD adherence and the impact of the economic crisis. So we conducted a qualitative study, 25 face-to-face interviews with a purposive sample of generally healthy adults. To assess adherence, we used the 14-item Mediterranean Diet Adherence Screener, or MIDAS, and we relied on a semi-structured interview guide on barriers and enablers of adherence. As for the key findings, most participants reported a moderate Mediterranean diet adherence. Many participants maintained or improved diet quality. Concerning the impact of the economic crisis, participants reported higher consumption of local and traditional foods, mainly due to decreased availability of imported products. And as for the key determinants, individual reported attitudes, beliefs, trust in food quality as important factors to adhere to the Mediterranean diet, and environmental factors such as food availability, accessibility, and proximity. And one important factor emerged from these interviews, that convenience is often prioritized over cost. So, as a conclusion, Despite economic constraints, diet quality remained a priority. Leveraging traditional local foods and accessibility may strengthen the Mediterranean diet adherence. Our final study was a cross-sectional study aiming to explore socio-cognitive and environmental determinants of MD adherence using the socio-ecological model. So we conducted an online survey in both English and Arabic, distributed between November 2023 and January 24. We included 304 adults. We used also the Mediterranean Diet Adherence Screener, MIDAS, as a screening tool for dietary adherence to the Mediterranean diet. And we conducted bivariate test and multiple regression analysis. The study tool was a questionnaire covering different aspects emerging from the socio-ecological model: socio-cognitive factors, attitude, subjective norms, intention, knowledge, social eating habits, food accessibility, affordability, and availability. Attitude items showed poor response quality and were excluded from the analysis. The key findings: Mediterranean diet adherence was estimated to moderate with a score of 5.97. Only 4.3% had high adherence, and the main determinant identified was perceived behavioral control. Therefore, enhancing perceived behavioral control through practical and context-specific interventions is especially crucial in crisis-affected settings. To conclude, Mediterranean diet adherence remains low to moderate. Evidence is primarily emerging from European contexts. Data from Middle Eastern countries is scarce and fragmented. In Lebanon, both quantitative and qualitative findings reported a moderate adherence. Qualitative findings highlighted maintenance or improvement in some individuals. Perceived behavioral control was the strongest predictor of adherence in Lebanon. So adherence is shaped mainly by a complex interplay of individual perceptions, family-based cultural transmission, environmental constraints, food availability, convenience, and the crisis context. Lastly, from evidence to action, Mediterranean diet is a living heritage. It's not just food, it's like a dietary cultural pattern, and it needs to be protected. So this thesis is setting a stone in the road of promoting this dietary pattern. Thank you for your attention, and I give the word back to the pro-rector.
Thank you very much for your clear presentation. It's now time to start with the opposition, and the opposition will be opened by the chair of the assessment committee, Professor Krohne, Professor of Prevention and Community Care at Maastricht University.
Thank you. Dear candidate, I've read your thesis with great interest, and I already congratulate you and your guidance committee for this interesting thesis. I was really interested also in the fact that you have looked at the economic crisis, and so that's already, I think, and I saw that COVID also led to positive aspect, that they led to better eating habits. That's a good thing. So we have to have sometimes a crisis, I think. Not the crisis that we have today, of course. You have chosen to include a wide range of age group in the qualitative study, but also to exclude some of the. You have quite some strict exclusion criteria, meaning that I saw that you excluded people suffering from chronic illnesses, comorbidities, and those at high risk of nutrition-related disorders, such as inflammatory bowel diseases, cardiovascular diseases, diabetes. And I was reflecting on that. So does that mean that you actually excluded nearly everybody from to. So I was wondering, how did you select the people that you included in the interviews, and also why did you choose to exclude all these people?
Thank you, highly esteemed opponent, for your comment and for the question. In fact, from the beginning of the study, our main aim was to have an idea about the general population, the healthy general adult population in Mediterranean countries. And for this purpose, even the systematic reviews were conducted on specifically healthy adults living in Mediterranean countries. Both studies conducted in Lebanon included healthy samples. In fact, as you have noticed, there are a lot of the population that would be excluded due to chronic illnesses, even if they were gastro-related, not only diabetes, for example.
But then I would like to interrupt. But you also excluded the ones with an increased risk. So does that mean that everybody with overweight or obesity has been excluded?
Yes, we actually included people with a healthy range of BMI, in fact. And this is for the purpose of having an idea about the adherence of the general healthy adult population in Mediterranean diet. In addition to that, people with chronic diseases or at risk of chronic diseases might have specific dietary requirements. They are on specific diets, so this might affect their adherence to the Mediterranean diet. And for this purpose, we decided to exclude them.
So you only have to, also so then when they smoked, they were also excluded.
No, actually, smoking was not part of.
Yeah,
it was not part. We mainly excluded people with like either diagnosed conditions or at risk of certain conditions that might lead to dietary modifications. So
just related to diet, not to actually health conditions, for example, because cardiovascular disease, I can imagine smoking has an important influence on that, but that was not the reason to exclude them.
Exactly.
Yeah, okay, yeah.
Definitely.
And if you would reflect on this, if you would have included them, what do you think? Would you find different findings, or what are your ideas about that?
I would say that because these types of conditions might lead to special dietary restrictions, this might affect the level of adherence, even though I would categorize the patients, because if we were considering patients with cardiovascular diseases, for example, they might benefit from following the Mediterranean diet due to its content of healthy fats. So this might improve the level of adherence, possibly. We have to search, we have to conduct a study to know for sure. But I would say that if they are following a diet that is protective against cardiovascular diseases, this might improve the level of their adherence. However, for example, certain gastrointestinal disorders might be limiting the adherence due to its high consumption of legumes and fibers, and this might affect the level of their consumption in these food groups.
So then you think, okay, I can imagine, I can understand that. Yeah. But then another question, because you also said that you use the qualitative interviews to inform your quantitative part, so the last chapter, chapter 5. And I was wondering, could you, because I was looking at both papers, and I wonder how did they actually, how did the qualitative part, how is it integrated in the quantitative chapter? Because sometimes I was not sure. For example, the economic crisis, how was it integrated in the quantitative part, for example? Yeah.
Thank you for this observation. And in fact, this is not clear in the manuscript. However, all the studies built on each other. So the second systematic review on the determinants of adherence informed our decisions to include certain constructs in the interview guide of the qualitative study. And then themes emerging from the interviews, from the qualitative interviews, have directed our choices on elements to include in our questionnaire of the quantitative study. So basically, it was like a chain building on each other. Certain responses from the interviews in the qualitative study have led us to include certain aspects, notably, for example, if I remember clearly, there was the question of trust, of food safety, of food availability. There was also the attitude elements, the perceived behavioral control.
You say, okay, then we use them and we translated them in this quantitative question. But then the economic crisis, that was less, because that was only included in the income aspect or something like that. Or how did you include the economic crisis then in the aspect? Yeah.
So the economic crisis basically was a key element in our interviews in the qualitative.
Not in this one.
Yeah, and then in the quantitative analysis, we have mentioned in the introduction of the questionnaire specifically that we aim to investigate the level of adherence and the determinants in affecting the adherence to the Mediterranean diet during these years of economic crisis. So the participants were aware that we are focusing on the current situation that was lived by all Lebanese in the moment. So it was a cross-sectional study investigating.
Yes, I saw that. Yeah. So that's different. And do you think that you have managed to have this reflection on that? Were they able to do that?
Thank you for this observation also. It was really a very crazy situation back then. And I wonder how much people were, in fact, in the state of mind of participating and to this question, to this study. However, this was their perceptions in the moment. Mm-hmm. So I would say that it was reflecting the way they are doing or what they are doing, how they were eating in this particular period and moment. So I would say with definitely some biases, but it gave us like a fair idea of how things were.
Thank you. I think that, because I know it would have been better to made it a natural experiment actually, but then we are not always have the data. Yeah. I also had a question on attitudes, but I won't ask them anymore because you excluded them. I was wondering. Yeah. I will ask that later.
Thank you.
Thank you.
Thank you.
Thank you, Professor Kronen. The opposition will be continued by Professor Platt, Professor of Nutritional Physiology at Maastricht University.
Thank you. Dear candidate, I also would like to congratulate you and also your team for this beautiful dissertation. I read it with great interest, and it was written in a very accessible way, so that was very pleasant to read. In Dutch we say it las als een trein. And it's also a very relevant topic because dietary adherence, well, you know, it's always a complex situation, how we can improve it. So it's an important topic as well. So looking at the data, you also showed it in your presentation. The data from Lebanon showed us that the perceived behavioral control was a very important determinant of adherence. So I was wondering if it is really one of the key components to increase adherence. So how can we use this knowledge? Do you have any thoughts about that? Because now it's an observation, but how can we implement it?
Thank you, highly esteemed opponent, for your positive remark and for the question. In fact, we as a team, we were reflecting on this particular results. And in fact, what I retained from the study is that knowledge alone, whenever it's dietary habits and dietary knowledge, we always think that we need to educate people. We need to make them understand how should they eat, what should they eat, what they shouldn't eat. But what we lack, or what we forgot, or what we forget about is a very important factor. How to make them entitled, or how to make them confident about their possibility of adhering to such a diet. So we can think about having time to cook, cooking skills, knowing the type of food that they can get from the supermarket, not restricting them from certain food items, but rather giving them other options so they aren't aware about, or tuning the recipes that they are cooking at home. This would make them more confident, and this would come easy, a natural way then to adhere to this dietary path.
Yeah, that's clear. So I understand. So that's a very practical implication. And when you think about that, is it then also can you extrapolate this finding from the Lebanon situation, maybe to other healthy diets, to other places on the world, or is it a specific observation for there?
Thank you also for this broader look. In fact, for the Mediterranean diet, the dishes, the recipes are a little bit complex. They are not straightforward, and there is a touch to the recipe. There's always spices added. And so tuning the recipe and formulating it is not straightforward. Nevertheless, I would say whenever any individual on any dietary pattern, if they have not only the knowledge, but they have the skills, the time, and they are definitely willing to do it, they would benefit from not only educational interventions, but rather practical interventions.
Yeah, as you explained. Okay. So we should also keep it in mind for example, the Dutch situation. In chapter 2, you showed that there was no real influence of age and gender in adhering to the Mediterranean diet. And especially the observation of age surprised me a bit, because you also found that the family-based cultural transmission was very important. So if I then translate that a little bit, because you mentioned it also, the intergenerational sharing, to me that sounds like the elderly are educating the younger people. So then I would expect that the elderly are more adherent. So then why did age not pop up as an important factor to explain adherence?
Thank you, highly esteemed opponent, for this very important, and it was a question in my head also whenever we had these results in the systematic review. But I don't have a clear-cut answer to know this. We need to investigate it more, definitely. Nevertheless, I would say that the studies included in the first systematic review emerged mainly from European contexts. Mm-hmm. I'm not sure how culturally these dietary traditions are transmitted from one generation to the other. I would reflect on the Lebanese situation, for example, or the Middle Eastern situation. And here, from an observational point of view, and this also needs to be tested, but from an observational point of view, there is always the story of a grandmother educating her mother on a particular way to cook certain dishes, traditional dishes. And this is what the mother do to her daughter. This is actually our case. So in fact, this generational cultural transmission is very pointed. The reason why we didn't find such correlations in the first systematic review might be related to a cultural context more than the diet, the Mediterranean diet itself.
I understand. So thanks for explaining. Maybe I have time for one short question? So in chapter 3, there was also an observation that I did not fully understand, because There you found some of the predictors, such as a higher socioeconomic status, but at the same time also being unemployed, being a job seeker. So that sounds a bit like a contradiction. Can you explain those findings?
Thank you also for this remark. In fact, we interpreted in this particular study as they have more time, even if they are a job seeker or an unemployed individual, they have more time to put effort in cooking. So it's mainly the lack of time that's driving people away from adhering to this particular dietary.
So that's also why being retired also was a positive.
Good. Yes.
Yeah, so it's basically time.
Time.
It's also an important observation. So thanks for the answers. I'm happy and give the word back to the prorector.
Thank you.
Thank you, Professor Plat. The next opponent is Professor Steenhuis, Professor of Prevention and Public Health aan de Vrije Universiteit Amsterdam. And she's present online. Please.
Yeah?
Yeah.
Yeah. But first I would like to compliment you on the work you've done. The dissertation contains 4 papers, all of which have been published or accepted for publications, and the studies were carried out under difficult conditions. Nevertheless, the research methods used are well applied and clearly reported, so compliments for that for you and your team. I have a question about the research methodology you used. Your research questions cover multiple levels of the socio-ecological model, in which you want to include both the individual and the environmental factors. However, the research methodology is mainly in line with the individual level, qualitative interviews and a cross-sectional questionnaire study. So which methodology or methodologies could you have used additionally to focus more on the environmental levels, other than how individuals perceive their environment? Maybe you can reflect on that.
Thank you, highly esteemed opponent, for your comments and for this question. In fact, originally the project was designed to investigate not only individual interpersonal factors, but also broader environmental factors in a more or less objective way. Nevertheless, due to the situation that was going on in the country back then, in the economic situation, the political instability, this prevented us from looking into policies that were enacted in the country in this period, to do market study, to objectively have an idea about food availability, the staple food that are available in the markets, or the unavailability of certain imported items. So market studies and study of food policies in the country could have informed us in a more objective way about the environmental factors that could be barriers or enablers to the Mediterranean diet.
Yeah, and do you also have any ideas about how to study the interaction between the different levels of the socio-ecological model?
In fact, the socio-ecological model is structuring or categorizing factors into different layers, and the individual factors are nested in these different layers of determinants. So basically, the environmental factors would have an influence either directly to the individual factors or indirectly via interpersonal factors. And interpersonal factors would affect directly also the individual determinants. I would say this needs to be very studied in order to have a clear cut answer about it. But reflecting on it from my point of view, I would say that the policies, food pricing policies, could affect the decision of the consumer of purchasing certain food items. So pricing policy, availability of items in the market also these factors could have an influence on the adherence to the Mediterranean diet.
Thank you, clear. Then I have another question. To what extent did you include concepts such as health literacy and food literacy in your studies? And what is more important, in your opinion, to focus on the health literacy or especially food literacy?
Thank you for this also important observation and question. I would say both are important, definitely, because we chose healthy adults in our sample. In this particular case, I would say food literacy is important. And this is why we asked questions about knowledge, for example, in the cross-sectional study. And in the qualitative study, before we started the interview, we have informed the participants about what is the Mediterranean diet, what food should be included in order to have an input about the determinants for this particular dietary pattern if they were not originally adherent to this dietary pattern. So knowledge was included in both studies that are conducted in Lebanon. But
sorry to interrupt you, but what's according to you food literacy and what's the difference with knowledge?
So food literacy, in my understanding, food literacy is the different types of food groups. For example, what are the sources of starch, what are the sources of proteins, fibers, etc. The dietary pattern is specifically what are basically the items or what we choose as food to be adherent to a particular dietary pattern. So they are, in fact, and I totally agree, there is a nuance between like food literacy and knowledge, definitely. But I would say that we have we tried to estimate or the knowledge of the participants, if I want to be correct, more than food literacy, as I say.
Yeah, I would say food literacy is a broader concept than knowledge alone. But let me go to my last question, which is more about the intervention. Based on your results, what kind of intervention and more specific, which behavior change techniques would you like to use in an intervention? So let's focus on the behavior change techniques.
Thank you for this also comment and question. As interventional studies, if we want to continue this project and like conduct intervention studies to see if they, in fact, if we have like indirect influence between perceived behavioral control and Mediterranean diet adherence, I would say we can like conduct more focused groups where we provide participants with practical skills, practical cooking skills, where we highlight the alternatives to unhealthy choices or the alternatives that could enhance the adherence to the Mediterranean diet among participants, and then test their adherence level after a certain period of time. Or we could also like conduct a policy, a pricing, a market study to see how foods are priced in Lebanon during the period of the economic crisis, and how is this affecting, in fact, the purchasing power of the Lebanese consumers. So, like, these are things that comes in my mind, on top of my mind, but things could be investigated definitely in much deeper and further ways.
All right, thanks for your answers, and I give the word back to the prorector.
Thank you.
Thank you, Professor Steenhuis. The next opponent is Dr. Risk, Assistant Professor of Nutrition at the Lebanese American University in Lebanon.
Thank you. Dear candidate, I've read your thesis with great interest as it addresses a relevant topic, and specifically the positioning of the work that you have done within the context of the economic crisis adds novelty to this field that is typically studied under normal and stable socioeconomic conditions. In addition, the integration of systematic review methodology and mixed methods grounded in the socio-ecological model reflects scientific maturity. And above all, executing this work amid the crisis in Lebanon is truly commendable. And for all of that, I congratulate you and I extend my congratulations to your supervisory team. And now I would like to raise 2 points that I believe would further strengthen the scientific robustness of your work. My first question relates to the tool that you have used in chapters 4 and 5 to assess the adherence to the Mediterranean diet. So why did you choose the 14 MEDAS, knowing that it has not been validated in Lebanon and typically it shows fair to moderate validity across Mediterranean countries?
Thank you, esteemed opponent, for your comments and for your question. In fact, I agree. We have validated instruments like the Lebanese Mediterranean Index that is validated for the Lebanese population that would give us a more credible estimation of the level of adherence in Mediterranean, in Lebanon in particular. Nevertheless, the choice to use the MEDAS was mainly for 2 reasons. One, for the purposes of comparability with other Mediterranean countries, with adherence level estimated in other Mediterranean countries. So comparability is comparability of results between our results and other conducted in Mediterranean regions. And 2, mainly for the practicality of the MEDAS, because it's a screener, it's shorter, and it gives an estimation of the adherence to the Mediterranean diet. And the context back then in Lebanon was not very, we wanted to make the focus on the determinants and to try, so we didn't want to enlarge the questionnaire more. Therefore, we chose to use this short screener in the study, basically.
So do you see any research implication based on this discussion, like maybe, for example, validating the MEDAS specifically for Lebanon?
Thank you for this comment. And in fact, this was something that I do think about a lot. It is a very practical tool. It's a short tool and it's widely used. Validating it in the Lebanese context, it should be a very important thing to do, in fact.
Thank you for that. So my second question also relates to the tool that you have developed based on your findings in Chapter 4 and have used in Chapter 5 in order to assess the determinants of adherence. So it is commendable that you have grounded it in qualitative data and anchored it within the socio-ecological model. And I'm also interested to know whether you have conducted any psychometric validation of this tool before administering it.
Thank you, esteemed opponent, for your comment and question, actually. What we did, we piloted our testing tool. We piloted the interview guide before starting it, and then we did a pilot study also before launching the questionnaire in the quantitative cross-sectional study. So I would say that the tool was piloted in the Lebanese context, but not like validated. And this was like one limitation that is mentioned in our dissertation.
Yeah. And maybe you can think of potential research implications as well, specifically through psychometrically validating this tool so that it could be used in other studies as well. I still have one question, and it's a comparison of your results with other studies that are conducted in Lebanon outside the crisis. So specifically, I'm referring to the two studies by Naja et al. Published in 2025 and by Zaane et al. Published in 2024. Both studies are conducted on a nationally representative sample with more than 2,000 participants in each study. And these two studies have highlighted that men, people who smoke, and younger adults are less likely to adhere to the Mediterranean diet. So in your thesis, you didn't find such findings. So what could be the reasons behind these differences between the findings that you provide and those conducted in or provided in these two studies?
Thank you for this also very important comment and sharing these results that are recently published, but conducted outside the economic crisis, in fact. I would say we, in our studies, both studies, the qualitative and the quantitative, the main focus was to investigate environmental factors and sociocognitive factors. So the main purpose of the interview guide in the qualitative study and then in the questionnaire of the cross-sectional study was to basically look at environmental factors and interpersonal factors and sociocognitive factors. The factors that you have mentioned most probably are, as you said, they affect the adherence in a negative way, being a man, a smoker, lower age, and they were conducted on a nationally representative sample. Our sample was a convenient sample, so also this could have played a role in these diverging results, I would say. So basically, the aim, two important things, the focus of our studies, the aim of the study was one, and two, the representative of the Lebanese population.
Perfect. Thank you so much. I give the word back to the prorector.
Thank you.
Thank you very much, Dr. Husk. The opposition will be continued by Dr. Gerards, Assistant Professor at the Department of Health Promotion at Maastricht University.
Thank you. Dear candidate, let me start with giving you and your team compliments for this great achievement. You can be very proud of this well-written thesis, which I very much enjoy to read. The thesis consists of two systematic reviews, which means a lot of work and a lot of patience, a qualitative study and a quantitative studies. All of this has been done under very challenging conditions, and I think you can be very proud of this. Of course, I'm also here today to ask some critical questions. My first question is about interventions. Although you did not conduct an intervention study yourself, I think all of this work is also done in order to inform intervention developers. Can you please reflect on what your recommendation would be based on the findings of the thesis, where you would focus on for intervention developers? And in the answer, I would like you to focus on which determinant is most important to change and why.
Thank you, highly esteemed opponent, for your positive comment on the study and for the question. In fact, and as we discussed it in the discussion and the impact of the study, if we would like to conduct interventional studies to investigate deeper the determinants affecting the adherence to the Mediterranean diet, I would say conducting a mixed approach, like conducting questionnaires, cross-sectional studies, in addition to follow up using quantitative or focus groups, interviews with the participants to see if this would change, or if the education that we provide could change the results, the outcomes. So basically, conducting educational sessions, but on the practical aspects of Mediterranean diet, such as providing them with tools, practical tools to help them adhere to the diet, and then following up using, for example, focus groups, interviews, or short questionnaires in order to see the outcomes of these interventions could be one thing. Another thing could be to focus on the impact, or design interviews, qualitative studies, to focus on particular levels of the socio-ecological model. For example, the influence of specifically the environmental factors on the adherence to the Mediterranean diet, or specifically the interpersonal factors on the adherence, or, for example, specific socio-cognitive factors such as perceived behavioral control or attitudes in particular. So to fragment this whole model into interventional studies, smaller studies, focusing on a very specific objective, and using a mixed method, conducting the intervention and then following up with a different technique to see if this could lead to results.
Yeah, it's interesting that you mentioned that, because I read all the recommendations in the chapter, and I noticed that you mentioned a lot of individual level determinants where the intervention should focus on. For example, you mentioned knowledge, strengthening perceived behavioral control, but you now mentioned the socio-ecological model. So actually my question would be, you addressed it already, based on what finding would you say we should focus more on environmental level factors?
Thank you for this important question as well, because actually the outer levels, the environmental, political, economical level, are particularly pertinent in the context of economic crisis. Mm-hmm. So whenever we speak about economic crisis, these factors become like the norm, or the important factors influencing dietary patterns. So this is important to consider as a cornerstone in any intervention.
Okay, thank you. Then I would like to continue with my second question, and for that I'd like to ask the paranymphs one paranymph to read the second proposition.
In the context of the crisis in Lebanon, family-based cultural transmission seems to play a more prominent role in shaping adherence to the Mediterranean diet than influences from friends and colleagues.
Yes, thank you. I was very enthusiastic when I read this proposition, and I can imagine reading your thesis that it was mainly based on the findings of your qualitative study, chapter 4, because you mentioned there that participants indicated that family norms influences override other social influences. But when I continued reading and I continued to chapter 5, I was a bit disappointed because you there only included one family-related variable, and that was eating with household members or sharing meals with family members, and you did not include any other parenting-related variable in the study. Can you explain me why you made this choice?
Thank you also for this observation. Actually, in the questionnaire of the cross-sectional studies, there were a series of questions on different interpersonal factors. Mainly, we asked about the influence of peers on eating behaviors, enabling adherence to the Mediterranean diet, or as a barrier influence to the Mediterranean diet, about colleagues, about friends, and about family members. Mm-hmm. So on this particular level, we have asked a series of questions. One important thing that stood from the qualitative study, as you mentioned, was the impact of the family transmission, the intergenerational transmission. And this has been shown in the cross-sectional study also, but not in a significant way. So basically, I would say that the questionnaire itself, our questionnaire in the cross-sectional study, mainly the amount of questions on the environmental factors and on the individual socio-cognitive factors might have affected these results and attenuated this relation, I would say, because our focus and mainly the questionnaire asked too many questions about socio-cognitive factors, attitude, perceived behavioral control, knowledge, motivation, etc., and on environmental factors. And this particular interpersonal factors was not like extensively tested or asked about in the questionnaire. This could be a reason.
Yeah, so if you would do it another time, you would ask
More
questions or less.
About if we want to focus on the interpersonal factors, I would like design an extensive questionnaire asking different questions about the different influences.
Yeah, okay, yes. Thank you. I give the word back to the co-rector.
Thank you, Dr. Gerards. We now come to the last opponent. It's Dr. Bessems, assistant professor also at the Department of Health Promotion.
Thank you very much. Dear candidates, it's a pleasure to be here today. And first of all, I'd like to congratulate you, of course, and the members of your team for the nice work you have been doing. I really enjoyed reading it, and I think you've received already a lot of compliments, which I fully agree with. So I'll go to my question quickly. My first question is about the characteristics of the Mediterranean diet in Lebanon. And although this is not reported in detail in your study, I can imagine you know quite a lot about this, also about the details of the Mediterranean diet, since it was also part of the measures you used. So my first question is, in the different chapters of your thesis, you refer to adherence of to the Mediterranean diet in general, but did you also have a look at the different types of food groups within this Mediterranean diet? And do you also know which food groups were specifically problematic for the people to adhere to in Lebanon?
Thank you, highly esteemed opponent, for your comments and for the question. As discussed with Dr. Riz a minute earlier, the particular tool, the MIDAS tool, is a screener of 14-item questions. So I would definitely say if we want to look more into the different foods or food groups, the staple food of the Mediterranean diet, in Lebanon in particular, we need to use another validated tool for the Lebanese context. The MIDAS in particular asks 14 questions about the 14 important food items. I would say this, they ask questions about olives, consumption of olive oil, consumption of meats, consumption of fruits, vegetables, among others. Nevertheless, it has a particular scoring mechanism where if the participant is not adhering or abiding by the recommendation of the Mediterranean diet, he would have a 0. And if he adheres, he would have 1 point for this particular question. And this is computed to 14.
Yeah.
And
yeah, I understand, but then still, I think for these 14 items, you still have some insight where the people scored higher and where they scored lower. So did they adhere to it?
Yeah, definitely. As you have mentioned, especially in the cross-sectional study, we have noticed that they adhere more to the consumption of olive oil, olive products, because this is an important staple food, less to fish, for example, if I recall. Vegetable consumption was fair consumption, fruits also. So the problem, I would say, was mainly related to fish consumption, fair within the legumes part, fair to low, basically. Vegetables and fruits are fine. So basically, yeah. This is, yes.
So some very specific products which were more problematic for the population. Would you then also see, I'm not sure if you already know this, but do you also see difference in the moments of day when people consume their diets? For example, breakfast compared to the evening. Do you have any insights on that as well?
Thank you for this question. Actually, no, the questionnaire didn't ask question about how foods was spread during the day.
Yeah, I understand. So what I'm trying to get to is that I believe the Mediterranean diet is kind of an umbrella term for a complete diet. While when we look at determinants, we often also look at very specific behavior. For example, breakfast consumption, fruit consumption, fish consumption. And now you have conducted a determinant study on this complete umbrella term, Mediterranean diet. Could it be that if you had specified it more specifically regarding to fruits or fish consumption or breakfast, for example, you would have found different outcomes in your determinant studies?
Thank you for this important perspective. And being a dietitian myself, coming from a nutrition background, I totally agree with your comment, with this observation. Repetition or distribution of food throughout the day would affect the Mediterranean diet adherence. Specifically that, for example, to adhere to the Mediterranean diet, there is a traditional breakfast, the traditional Mediterranean way, consuming more white cheeses, yogurt type food, more fruits, vegetables, olive oil. Even the dinner would be different in the Mediterranean diet. So
If you want to finish your answer, or you're okay.
I'm good, I guess.
Okay, that's fine.
Thank you.
Cécile Obeid, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you.
Cécile Obeid, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Kremers is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Cécile Obeid, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, secretary, and the other members of the committee, and affixed with the official seal of the university.
Dear Dr. Obeid, dear Cécile, today I have the honor to be the first to congratulate you on this milestone in your career, also on behalf of Anke and Steph, of course. And we would like to extend our congratulations to your friends and family, especially to your husband, your children, Christian and Carl, and your mother and sister and other family present, who have supported you throughout this journey. You have every reason to be proud of your achievements. You've written a very interesting thesis. All chapters have already been published in scientific journals, and several are already widely cited, one nearly 200 times. So that's a clear indication of the relevance and impact of your work, both for science and practice. You first approached us in 2019, as you had the ambition to pursue a PhD. Your plans were ambitious, not only because of the studies you envisioned, but also because you also had to complete this project alongside a demanding job and a family for which you often carried the primary responsibility, as your husband was abroad for work for extended periods. And the circumstances in Lebanon under which you conducted the research also made this achievement more extraordinary. It has been heartbreaking to witness Lebanon descend into political and economic crisis, compounded by the devastation of war. I know that you're worried about your friends and family at home in Lebanon. So it's even more good of you that you have found a way to focus on your research. The conditions were very difficult, so sometimes the progress was slow, and understandably so. And yet, what has been truly inspiring for us is how you persevered. You often indicated that your PhD project was like a ray of hope amidst the turmoil. And the challenges never discouraged you. You kept your eyes firmly on the goal. And Anke and I both remember a meeting where you casually mentioned that you would need to cancel our next appointment because you were about to give birth to your youngest son. We didn't even know that you were pregnant up to that moment. And it shows your commitment to the project and your resilience. In 2023, you came to visit Maastricht together with Maya to take part in the intervention mapping course. And until the very last moment, it was uncertain whether you could actually come because of the delays in the visa. But only with a slight postponement, you made it, and it was a pleasure to finally meet you in person. And then, in the midst of the crisis, you faced another life-changing decision to leave everything behind in Lebanon and move to France. That transition brought new challenges, finding a home, arranging schools for the boys, and rebuilding stability. Yet once the dust settled, it seemed that it also strengthened your determination. After the move, you made tremendous strides, not only in the project, but also in the development of you as an independent researcher. Looking back, you can be deeply proud of your path that you have traveled. And now, today is your moment. We are very proud of you, and I know that your family, friends, and colleagues share that pride, even if not all of them can be here today physically. I know that you feel their support in your heart. It's now time to celebrate not 1 but 2 days, because tomorrow is also a special day. It's your 40th birthday. But first, we celebrate your new title today. Congratulations. Enjoy this moment. You've truly earned it.
Dear Dr. Obeid, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. I also congratulate your family members who are present here. It's very nice to see some people in the audience, and especially that doesn't happen very often, as many children as adults in the audience here. And it's worth mentioning that the children are really great, because we didn't hear them during the defense. It was just now that I heard a little cry somewhere. Thank you for that. I also like to congratulate your supervisors with this nice PhD defense. I'd like to thank the members of the committee for the time they have invested in preparing for this meeting and being here. A special thanks to our guests from outside Maastricht University, Professor Steenbeek. And thank you, Dr. Risk, especially from Lebanon, because we are all aware that the situation in Lebanon is very difficult at the moment, and it's very brave of you to be present nevertheless here online. Thank you for that. Then I think I can tell you the impression of the committee of your defense. It was, you showed that you're really on top of the topic that you have studied. You showed that you're at ease with the defense. You showed competence and knowledge about the topic. And I think that's really very important for a new doctor from Maastricht University. So congratulations with that. I realize that it's very difficult to combine science, family, and all the rest. So I think it's good that now it's time to relax and enjoy the day with family and friends, probably later on.
Thank you.
And with this, I close this academic ceremony.
Please all rise. May I invite the committee? You in the
I
middle,
can just
panelists, next.
Yeah, I believe that we should stay online.
Maybe you can make a picture with also the online opponents as well. Maybe 1 or 2 rows. Easier. Alleen misschien wel even aan te komen.
Professor Steenbeek,
Yeah,
still
Steenhuis.
online? Oh,
That's okay. Cécile, I'd like to congratulate you on this terrific job you did with your dissertation and your defense. So congratulations for you, your supervisory team, your family and friends. You did really well. You can be really proud. And I hope you have a wonderful day celebrating it. So good luck and again, congratulations.
Thank you so much for your presence and for your nice words. Thank you so much.
Dr. Risk?
So, Dr. Obeid, as a fellow Lebanese woman, academician, and researcher, I cannot tell you how proud I am of this achievement today. So I really congratulate you for this amazing job. I extend my congratulations to your supervisory team, but also to your family. I believe that this is a journey that you all took together, and this is why I congratulate you all. I wish you all the best in all your professional and academic endeavors, future works. And I really hope that the work you present as part of this thesis would feed into targeted interventions that would enhance the adherence to the Mediterranean diet in Lebanon. So that would not only be a thesis or a research work, but also an actionable intervention in Lebanon. So thank you again for involving me in this committee, and I wish you all the best.
Thank you so much, Dr. Rizet. And we hope that a collective researcher effort could be established in Lebanon to move things forward.
We will, may I invite you all to go to the stairs where we make another picture, yes? Thank you.